Welcome to Comp Days 2024, everyone. I'm Ann, your enthusiastic wound nurse. Here today we're going to have a whole lot of fun with negative pressure wound therapy and ostomies. So two things that we don't see very often, but we need to know what to do when we have them. And Dr. Schwab does have a colostomy coming up October 15th, so this is good review. So for those of you that are familiar, great, just watch it and gain a little refresher. But we have a lot of new nurses who might not be so familiar. So all of the equipment is kept in the clean equipment room on Med-Surg. The VAC machine, the VAC Ulta, is capable of regular negative pressure wound therapy and installation therapy. The canister is the same for the both, but for installation therapy, there is a cassette that gets a 500 ml bag of saline with it so that it can instill. The installation therapy has another tubing for that fluid to go in. So these two are not interchangeable. So the installation therapy foam is a denser foam and it has two tubes. The regular normal black foam just has one tube. So they are not interchangeable. This is crazy expensive. This is regular therapy. So there's also different manufacturers. As far as drape goes, regular thin drape, they're all pretty much the same, but there is another form that's kind of waffly, and this drape is also a different type of drape. So you have to have compatible drape with the dressing that you're using. And this has different tubing because it has a different canister. So you would not remove something unless you are able to replace it 100%. So the best thing to do is to consult the physician that put it on or the wound nurse. So over here we have the different drapes. The drape is just as simple as 1, 2, 3. If you need to patch your negative pressure wound therapy, one of the biggest and most common problems is the leak alarm. So if you get a leak alarm, start with your cord. Make sure the cord is plugged in, make sure all of the cords that hook together are plugged in, make sure this connection is plugged in, and that your canister is plugged in. That's one of the main problems, is the canister being loose and then it's not getting its suction. Another problem is going to be when you come over to the site itself. So if there's not a good seal around here, you have to find out where it is. So you can literally just put your head down and listen to see where it might be leaking. If you can't find it that way, grab your stethoscope and you can go around and listen. Oh, there's the little hiss. I can hear it. So if you find that, then you can take a little piece of drape, and it's simple as 1, 2, 3. 1 first, put it over. Then number 2, make sure you're peeling off number 2. You do not want to see any lines on your skin. That's not good. So then if you still have a leak, oh, it's still leaking. So continue to do that. The trackpad is also a primary suspect for leak areas. You can use the drape that came with it. You can also use our Tegaderm, which is easy peasy lemon squeezy. All you do is take off the back, open it up, plaster it over the top. Optimally, you shouldn't have more than 3 layers on there. But if you are having a leak and you are able to get it by plastering on a few more, go ahead and plaster on a few more. You cannot have the wound vac therapy interrupted for more than 2 hours. So if in 2 hours you can't get a good seal, you can't get a hold of the wound nurse or somebody in wound therapy, then you would call the physician. If the physician says go ahead and remove it, what you'll do is you'll remove it and you'll remove it and you'll fill it with sterile saline soaked gauze. So all of this is sterile as can be. So to remove it, you would take a needle, and you want to know how deep your wound is. You wouldn't be just randomly poking that in somebody's body. So, and of course I have my gloves on and my PPI because I have my PPE because I don't want any PPE on me. So you take your needle and you would just put it in right underneath the track pad and fill it full of saline. And what you're doing is you're trying to soak that pad full of saline so that it releases from the skin better. Because this can be very painful removing that dressing. So when you're removing the dressing, you want to make sure that that patient is pre-medicated. Also for effluent, you might have some viscous effluent that clogs your track pad. So before removing the whole thing, what you can also do is you can try, if you've plastered the bejeepers out of it and didn't get any results, you can try just removing the track pad and replacing the track pad. Because think of a filter. If the filter in the sink gets clogged with hair and other nastiness, you have to clean it out. Well, kind of the same thing. So you can try removing the track pad first to see if that works. And what you would want to do is you would want to cut another rim of foam to go underneath your track pad before you put a new track pad on. So you would take off this old one, try putting on the new track pad, or put the piece of foam first, new track pad. If that doesn't work, then you'll have to replace the whole shebang. And you can do that, you can get some skin adhesive tape remover to get that pulled off. You want to be as careful as possible, and you want to use the least amount of drape as possible to protect their skin. We're always going to protect their skin with skin prep. And now here underneath we have nice beefy granulation tissue. Isn't that beautiful? Oh, that looks so nice. So we're going to rinse that out. We'll put our foam, so if we had to take the whole thing apart, we would put our saline soaked gauze in there and just put a dressing over the top until we can replace the whole thing. We want to protect the skin as much as possible by using skin prep, the least amount of drape, and the appropriate size. I'm just going to get rid of this, excuse me. And it's always good to have a bin, bring all of your supplies in a bin, and then also have a bin or garbage nearby so you can get rid of all your stuff. If you don't, this is a nice deep wound, so you would expect that you would have some bloody drainage in your canister. If you don't have bloody drainage, find out what the therapy is for. If it's for a shallow wound, or if you have maybe a skin graft and the therapy is on just to promote angiogenesis, to keep it clean, to get all those tissues coming together, you might not have any drainage. That's okay. Don't worry about it. Know what it's for. Is it deep? If it's a deep wound and there was a lot of drainage, now you don't have drainage, then you know there's a problem somewhere. You might have a clogged filter or something needs to be investigated further. For filling it full of saline, open up your sterile, these are sterile in package as long as they're not opened. So you can open this up, pour in your saline, squish it, squish it, squish it, squish it, and then with your sterile gloves, you can unwind it, find your end, find your end. So with your sterile gloves, you can find your end and then just feed it, feed it, feed it, feed it, feed it, feed it all in there until it's nice and filled. And then again, you'll cover it. You could cover that with a Mepilex border dressing just to keep everything intact. And anytime you're filling with the white foam, or anytime you're filling a cavity, and the same with if your foam dressings, you want to count the number. If you want to do one piece, if possible, but if not, make sure you document how many pieces of foam or gauze, etc., are what in there, so that the person removing it knows that they got everything out of there. Then we will move down to our ostomies. Woohoo! So here in-house, again, everything is on med-surg, in the clean equipment room, in bins. So we have, again, for those, there's a bin that says installation foam, and then there's the regular bins with tons and tons of black foam. For the ostomy things, there's a bin that has a lot of these folders, and this is an ostomy skills kit that we can give the patient, but it also happens to have nice cut to size in there. In-house, our general supply are the different sizes of the two-piece. When the surgeon does surgery, he's going to put a two-piece on with the clear faceplate so that he can see into it. Now these are kind of like Tupperware. So these are, you have to make sure that these are securely snapped together. And that might be kind of hard for some of our older patients with their dexterity, with arthritis. And also think if that's on you, trying to smash that down on. Personally, I prefer the one piece that we'll talk about in a second. But the surgeon will put on this two-piece so that he can see it, so that he can remove this and look at it. Also, in our kits that we have in-house, we have 70 millimeter, 57 millimeter, and 45 millimeter. We measure everything in centimeters except when it comes to ostomies. Then they do it in inches and millimeters. Go figure. So these will have this flange in here. This extra flange is to go in between the two to make this stick out further. And the reason you would do that is if somebody had a giant protruding stoma. Well, you don't want to compensate for the giant protruding stoma by having it stick out even further, making it obvious that they've got a giant stoma there. What you can do instead is reduce it with sugar. So what you would do, if they had a two-piece, you would take off the flange, and here's their giant protruding stoma. You'd take a little gauze, put it underneath, saturate it with the sugar, then put the faceplate back on and let it reduce down. After it's reduced down, then you can take the gauze out. If they don't have a two-piece, if they have a one-piece, what you would do is make sure that you're doing it on a day when it's going to be changed, and you can just cut into it. So the one pieces are glorious. These are glorious, glorious, glorious. They come in the ostomy kit that we can send home with the patients. You cut to size. So whatever size your stoma is, you cut to size. And then once you have that, save your previous cut. So that way you have your an idea of how big you need to cut the next one, and you would of course wipe that off. But save that for a template for cutting your next one. So after surgery, the doctor wants to see through it, and these are great to, you know, cover up the nastiness. Well, all you have to do is cut it out. So you can cut into those without any problem, you know, just the paper. If somebody has lumpy skin, you can use the Eakins ring. So people might have lumps, bumps, rimples in their skin and their abdomen, if it's close to the umbilicus, or they just have a big pannus. You can take an Eakin ring, and this is pliable. These are expired, so they're a little drier, but they're moldable, and you can put those in the creases because you want that good adherence. The best way to protect the skin is to make sure there's good adherence. So you can put this, you can cut this, you can put this around here as needed. I'm just gonna remove that. You can put this around here to get a good seal if there was any lumps, bumps, rimples, or if there was fragile skin around there. When you're changing an appliance, the first thing you do is gather all of your supplies. If you have your template, you cut out your previous one. When you're removing the old dressing, you're using push-pull. You're not ripping it off like a Band-Aid, because if you do that, you can cause folliculitis or skin irritation. We want to protect the skin, So, and sometimes they might have a wound under there. If they have a little wound, or if they have pyoderma gangrenosum, we'll talk about that in a minute, you would want to put a little silver dressing underneath there, and you can secure that with Duoderm, with this dressing, with the Duoderm dressing. So after your gentle push-pull removal, you don't use Pam cooking spray to remove it. If you must, you can use some adhesive remover wipes, but then you're going to have to make sure that that skin is cleaned well afterwards so that you get a good adherence. You remove it with push-pull. You take your Cavalon wipes, and if somebody has an ileostomy, you might want to show them how to use a toilet paper roll so that they don't have effluent. Oh no, oh, their effluent is coming out all over. Look at that. So you put a toilet paper roll with toilet paper in there, and that way they can clean around it without having all of that nastiness. And of course you would not have your hair dragging in the ostomy, but this is counties. So an ileostomy would have looser effluent, and you would want to teach the patient how to do that. So think of anatomy and physiology. You have the appendix in the right lower, ileocecal crest, then you have the ascending, transverse, descending. If someone has an ileostomy, it will be on the right, and the effluent is going to be thinner because it hasn't had time to absorb all the nutrients. If it's a colostomy, it's had a chance to go all the way up and around, and it'll be on the left, likely. The effluent will be denser because it's had time to get that fluid removed. The large intestine removes fluid, and it also absorbs vitamin K and some other ascorbic acids, B vitamins. Most of the nutrients are absorbed in the small intestine, in the duodenum, jejunum, and ileum. So if someone has an ostomy or a wound vac or any wound, they need a nutrition consult. Nutrition, nutrition, nutrition. So we're protecting the skin. When you're changing an appliance, I forgot to mention, the first thing you do is stick this in your pocket because that will warm it up. So you want that warm so that you can get a good adherence once you get that going. So you have it clean, you have the skin prep on, you have your appropriate size. Then you take your appliance, make sure you have your bottom secured, and you put it right over the top. And you want to go right around that rim with your finger, nothing sharp. You want to make sure you have a good adherent seal. And then you'll have the patient hold their hand over that for 5 minutes to help warm it up and to help get a good adherence. That's why I like to stick it in my pocket, because that kind of pre-warms it to give it a good adherence. And then that way when they start, oh, look at there we go. Everything is nice and contained. If somebody would have some peristomal skin irritation, we would do a crusting. So a crusting is with stoma adhesive powder, which is on the wound cart. If you had someone that needed a crusting, you would go to the wound cart, take the stoma adhesive powder, a medicine cup, go to the clean med area, pour some in, recap this, take your small portion. So I'm just going to pretend that this is the portion that we took out. It doesn't need much at all. You don't want to take that into the room because then it's got to stay there. So with a crusting, if you have excoriated skin, if you have moisture associated contact dermatitis, all of those things, and especially around an ostomy, that effluent is quite acidic. So you can do a crusting, and that helps protect and build up the skin. So with a crusting, we'll pretend I have my gloves on. You always start with the powder, and you'll just get that, just a light dusting. You don't want gobs and gobs of it. Then you'll take your Cavalon Skin Prep, and you're going to dab it. And you'll do that 3 times. I like to use a fresh Cavalon wipe with each layer. So the second layer, and you'll let that first layer dry a little bit. I'm just doing this for time's sake. So you let that first layer dry a little bit, then you go back, and 2 to 3 layers. You don't need more than 3, otherwise you're just creating gunk buildup. When a patient has a brand new ostomy, especially if it wasn't planned, that can be devastating. I'm just gonna move this over here. And of course you have all of your towels and washcloth. When someone has a brand new ostomy, it can be devastating. They need to know what to look for. So a new ostomy is going to be large. It's going to shrink up. So it's normal that they have a bigger one initially, then 6 to 8 weeks later, it's going to be smaller. So that's why the cut to size are nice, because you don't want to get a whole bunch of these pre-cut sizes and now we need the next size smaller. They'll have home health, they can help them with that. But they also need to know what's bad, very bad, black. If it's gray, dusky, black, that needs to be called immediately. We have all kinds of wonderful information packets for the patient. And what I like to do is I like to have them practice on their leg, because it's easy. It's easier to do something on their leg instead of where something is actually coming out. So they can practice cutting it out. They can practice preparing the skin. They can practice putting it on. And it gives a little bit of confidence, because it's like, well, I can do that. And then you just move it up a few feet wherever they're gonna do it. You can also practice cutting to size. There's little different size buttons you can put on. and the little sizing chart, and there's these little thin sheets that you can practice cutting. You know, you can find out what size. Oh no, oh that's, you want your wafer about a 1/4 inch bigger. So that one is about right, but I would even come in a frog hair. So you would cut that to that size and then transfer that onto your face plate. We also have the information packet that's got the different, these are the different one pieces that they can have. There's also a convex one in here. So if someone has a flat ostomy, right here, if someone has a flat ostomy, they would need a convex appliance. This is a convex 2-piece, and this is a convex 1-piece. So this is a nice cut to size, and what that does is it helps push down around that flat edge to get a good adherence, and also to protect the skin, because you want a good fit so that you don't get effluent leaking out all over. There are lovely laminated skills lists for the patient so that they can just go right down and, you know, from emptying the pouch to removing it to how to cut it and how to get onto, you know, get the new appliance on. And it's laminated, which is very handy when you're doing an ostomy. We also have beautiful info packets. So these folders are in the bin with all the supplies, with the 2-piece appliances that we keep in-house, and with, there are boxes of the patient teaching ones. There's information in this itself, and there's also these nice folders. So these folders have a nice, a great amount of information in them. The patient can take that home, they can take this home so that they can look at it. I also like the UOAA website, the ostomy, the United Ostomy Association website. They have a lot of great information. They're a great resource, especially if someone might need, might have trouble getting supplies. It's a great resource. And on comp days, I'm going to have 2 lovely posters filled with all kinds of funky looking things. You know, different problems. So, you know, the peri-wound skin problems are very common. And that's when we would do the crusting. Now this is candidiasis. So if we have candidiasis, what you can do is you can use nystatin or metronidazole powder in your crusting to help combat that, to help that heal. If there's an actual wound, you could use the Aquacel AG. This is pyoderma gangrenosum, which is very painful, and that it arises from an autoimmune disorder. If someone has Crohn's or ulcerative colitis, they would be more prone to the pyoderma gangrenosum, and you would treat that like a wound. You'd put the Aquacel AG underneath, put a Duoderm over the top of it, and then an appliance as usual. This is folliculitis from ripping the bandage off or from shaving, so don't shave and don't rip the bandage off. That's our prolapse that we had talked about. That's our flat one. This is maceration, and that is from, you can see that they probably had that opening cut too large. So we want to make sure that even if they're using one of these pre-cut appliances, if that hole is too big for what they have, you can use an Eken ring to get a good size on that. So, I hope you had a whole lot of fun today, and if you have any questions, feel free to ask. Thanks.